folks.
Morning.
Mike Benninghoff, one of the ICU doctors.
Morning.
Good morning, Doctor.
Nice to meet you. This is part of the healthcare team here.
Hi, I'm Lauren, one of the physician assistants.
I'm Beth, one of the residents.
Hi, I'm Lindsay, another resident.
I'm Jackie, one of the clinical pharmacists.
Hi, I'm Michael. I'm the respiratory therapist.
Hi, I'm Nancy Bunting, social worker.
I'm Jamie. I'm your nurse, of course.
I'm Donna Casey. I'm the nurse manager of the intensive care unit. It's nice to meet you.
Hi, I'm Rosemary, a dietitian.
What we're going to do now is discuss your dad's care here in the ICU, what happened and how he ended up here, and how we're going to try to make him better. Okay? Mm-hmm. Please feel free to ask any questions or interject any comments during Lauren's presentation.
All right, so this is Mr. Gervais. He's a 79-year-old male with a history of thyroid carcinoma, originally diagnosed in 2006, where he had a thyroidectomy as well as ablation, which reoccurred in April of 2009 in his thyroid as well as his lung. Also has a history of diabetes, OSA, paroxysmal atrial fibrillation, hypertension, bladder cancer, status post of TERP, and BCG, who came into the Wilmington ED early this morning, status post the PEA arrest at home. He, at home, had been complaining of worsening shortness of breath times 1 week. When they called EMS and they arrived at his house, he was noted to be in severe respiratory distress in the tripod position with an O2 sat of 68%. He subsequently became bradycardic and went into a PEA arrest. He was intubated in the field and received 2 rounds of CPR as well as epinephrine and atropine, with return of spontaneous circulation approximately 8 minutes after he lost his pulse. He was transported to the Wilmington ED where his vital signs were stable. He did have some dark blood coming from his endotracheal tube when he arrived. On my exam this morning, he was unresponsive. He is currently on the hypothermia protocol and is sedated with Versed, fentanyl, and Nimbex. In terms of his lungs, he had some scattered bronchi. His heart, normal S1, S2. His abdomen was benign. He had 1+ pinning edema bilaterally. His labs were notable for a lactate of 13. His BNP was essentially almost normal. He did have an anion gap of 18. His first set of cardiac enzymes were negative. His most recent ABG showed a pH of 7.33, a PCO2 of 42, and a PO2 of 146, and that was on these current ventilator settings. He has blood and urine cultures that are pending, though his initial UA didn't look to be infected. He had an EKG done in the emergency department, which showed sinus rhythm, didn't have any signs of ischemia. He had a chest x-ray which showed a left lower lobe opacity, which I think you might have on your computer.
Okay. We're going to talk about some of this imaging, and then I'm going to ask you guys a few questions, okay? Based on what you heard from Lauren, what kind of differential diagnosis can you generate using this chest x-ray?
So if you look right there, he could definitely have a pneumonia.
Mm-hmm.
I agree.
You could have a pulmonary embolus.
I agree with both of you. I think that pneumonia, PE, and CHF are all on the list of differential diagnoses. Let me ask you a few questions about how he was a week or 2 weeks before he was found pulseless. Did he have any chest pains?
No, not that I'm aware.
How was his activity level?
Not very active. The past couple of months, we've noticed him slowly decline in activities. He really just slept a lot during the day, either in bed with a CPAP machine or just in front of the TV in the recliner. He didn't drive anymore, and he was tired in the past week. He was short of breath, coughing a lot. We were concerned, but he went to the doctors and said, "Oh, everything's fine." So.
And he could go up and down a flight of stairs?
He had a lot of difficulty.
When he was coughing, was there anything that was productive about his cough? Or was it kind of dry?
It was dry. It was dry. And he had speaking, it was hard to hear his voice sometimes. He had to speak louder. But if he tried to speak louder, it seemed like he was giving a lot of energy, trying to use a lot of energy just to speak loud.
Had he had fevers or loss of appetite?
Not that I'm aware of, no.
Okay. Do you have any questions so far about what we've reviewed, or do you want to add anything to the presentation?
When he was 17, he had lung TB. When he was 21, he had kidney TB, and they removed his right kidney at that time. And this was in Europe. And then about the thyroid cancer.
Okay. Lauren, what else?
So just to review our plan for the day, so neurologically, status post of cardiopulmonary arrest, he's on hypothermia protocol, which will continue for 24 hours with a possible neuro consult when it's finished. Pulmonary wise, so we're going to work up different etiologies. Possible pneumonia, his cultures are pending, he's on empiric antibiotics. For a workup for a PE, he does have Dopplers of the lower extremities pending. Would you also like to do a perfusion scan?
I think it's very reasonable.
Okay. Otherwise, to work up for possible CHF, we're trending his cardiac enzymes. We're going to check an echo. And from a GI and renal standpoint, there are no active issues.
Jamie, as his nurse, what would you like to add to what Lauren had mentioned so far? Anything in the night sign out that had happened that was unusual?
Well, as Lauren said, he is on the hypothermia protocol, so he's on Nimbex. Pupils are and non-reactive since he's been in the ICU. He has had a lot of copious tan secretions. There is a culture pending, so we're waiting for that. Otherwise, he's synchronous on the vent. Is covered pretty adequately with sedation and pain coverage.
Excellent. Michael, he mentioned secretions are thick, but do you think it's impeding the ability for the machine to oxygenate or ventilate him?
No, we're just going to maintain him on current settings. We have the ventilator humidified, and we're using Mucomist for the secretions.
Jackie, from a pharmacy standpoint, what kind of medications that we are using here, maybe should we eliminate or change doses of them?
Well, being the fact that he's on the hypothermia protocol, he is on the fentanyl drip. So maybe to see if the nurses can try to titrate that down.
And what recommendations do we have from nutrition?
Well, when able to start the tube feedings, you may want to start with trickle feeds with an isotonic formula. I'll have the recs in the chart when you need them. Okay.
Thank you. We've talked about the variety of things here on rounds that can cause your husband's heart to stop. A lot of times we treat multiple disease processes and sort out and rule out what life-threatening conditions exist or not. So it could take some time to get to the bottom of what caused the problem. In the meantime, he's quite stable right now, and we're encouraged by some progress that he's made.
He's not in any pain, is he?
According to the assessment at the bedside by Jamie, his sedation and his pain is well controlled, and we strive to make sure that we keep his sedation and pain at an adequate level.
That's my main concern, is that I don't want him feeling anything. I don't want him in any pain. And as I grew up, he and my mother and I always talked about what their wishes were in this time. And he does not want any medical assistance. He doesn't want machines breathing for him. He has a living will. We can produce that if he want, but we know his wishes.
Donna, what kind of comments do you have about DNR status?
That's wonderful that you are aware of what his wishes are. We have so many patients whose families just don't know, so that's really a blessing for him. It's great if you could bring in a copy of his advance directive. We will put that on the chart. Lots of people say they would never want to be on machines, but given the option of, maybe there's a reversible process, would he want to be on the machines for just a short period of time so that we could see if we could get him better and through this? And then if it doesn't look like it's going to be reversible, we can look at again, making sure that we honor his wishes and not leave him on machines if it doesn't look like he's going to get better.
Yeah, and we know we can produce that documentation, and it's only the two of us, so there's no other families or family members you'll have to deal with.
Anyone else have any thoughts, questions, or concerns? We're available. I'm always on the unit here. Like I said, feel free to grab one of us if you have any questions. In the meantime, we're going to continue to push ahead here and try to get to the bottom of what's going on.
All right.
Okay.
Thank you very much, Doctor.